Hello, everyone. Welcome back. My name is Karan, and today we're going to be talking about seizure disorders. So we'll be talking about epilepsy, but we'll also be talking about other types of seizures and how we make that distinction. Now, I think these seizure disorders itself are a relatively straightforward topic, but I think there's some aspects that you need to get down really pat and understand well to get the topic well as a whole. So what is a seizure? A seizure is a transient manifestation of abnormal, excessive, or synchronous electric brain activity that causes convulsions, loss of consciousness, and or lapses of consciousness. What does this whole definition mean? So basically it means that something in the brain has abnormally fired and you have electric discharges that are causing a whole bunch of symptoms. These symptoms can be everything from motor symptoms to sensory symptoms, and even include loss of consciousness. So let's talk about this. The exact specifics of what's happening in terms of their symptoms may give us a relatively good idea of what areas are affected. And this is really important when it comes to classifying our seizure disorders. So before we go ahead and call a convulsive episode or a seizure epilepsy, there are a few things you need to understand. Not all seizures constitute epilepsy. For you to call something epilepsy or for you to call a seizure epilepsy, you have to have 2 or more unprovoked seizures more than 24 hours apart. Now, there's an emphasis on the unprovoked part, right? Because we need to consider what's causing these bursts of electric activity, what's normal, what's abnormal, and that's where that comes into the definition. So before you go ahead and memorize a long list of definitions and a list of triggers and causes, there's something you need to understand. We just said that in order for a seizure to be called epilepsy, it has to be unprovoked, right? Which means it should not have a cause that we can pinpoint. But then you go ahead and you read about epilepsy and you read about the various triggers of epilepsy, right? Sleep disturbances, stress, issues with sleep, genetic, hormonal, endocrine. And then you think to yourself, well, aren't they causes? And how does that fit in? Because we just said that for something to be epilepsy, you should not have a cause. But then we are here saying that things like sleep put you at a risk. So what's going on there? So here is the difference between a cause and a trigger. So a cause is a genuine pathology. There's something genuinely wrong, either on a structural level, or on a chemical level, endocrine. Something is going on that should not be happening. A trigger, on the other hand, is kind of something that's not great, but wouldn't be shocking, right? It's something that's usually non-pathological, and it's something that pushes a patient over the edge once they already have a predisposition towards something. So let me give you an example. Actually, there's an example on the next slide. So, so let's consider a case, and then you can tell me if this is a cause, if it's a trigger, or it's somewhere in between. So we have Mark, who's a 19-year-old stressed medical student. He's come into your ED with 2 days of 2 days of fever. He's developed some neck stiffness, and you think this might be meningitis. Considering how good you guys are with your infections, and because you've been to these lectures, you know to do an LP that comes back positive for streptococcus. You treat him with antibiotics, as you should, and steroids, and he seems to be getting better. But then 2 days later, while he's recovering, you get a page saying that he has a seizure, and you go to his room, and in fact, you do observe him having a generalized tonic-clonic seizure, which gets better within 2 minutes, and he seems to be really drowsy and tired for the rest of the day, although has no specific neurological findings. Now, my question to you is, was the meningitis a cause or a trigger? Now, going back to our basic principles, causes are usually pathological, and meningitis is pretty pathological. So I would say that meningitis is a cause. And therefore, very commonly, the mom might come and ask you, hey, doc, the seizure that he had, does this mean he has epilepsy? And then you would say, well, mom, no, he doesn't. No, it doesn't. Because for it to be called epilepsy, firstly, you need to have 2 or more unprovoked. he's only had one so far. So that's one thing. And secondly, he has meningitis. So the fact that he's had a seizure indicates that there might have been some inflammation in the parenchyma of the brain that's caused this abnormal burst of electric discharge, versus epilepsy, which is an unprovoked cause. And obviously here we have a provoking factor. And here we're just saying that this is probably a seizure, but it is not epilepsy. So here are some causes of acute seizures, including traumatic brain injuries, strokes, infections. Electrolyte imbalances are a very big one. Alcohol withdrawal, also a very big one, and a very big thing we look for in psychiatry, where we have patients with severe alcohol dependence coming in for detox. And then uremia as well, specifically. And then we have triggers of seizures. So things like physical exertion, alcohol consumption, having a fever, especially in young children, can lead to something called a febrile seizure. Flashing lights, sleep deprivation, hormonal changes during puberty. So as you can see, everything here is kind of normal part of life. Some of it's maybe you shouldn't be doing, don't consume too much of alcohol, but it's not pathological versus all of this, which is relatively pathological. So how do we classify seizures? So we had a classification system earlier. Now it's slightly different. So you might come across two conflicting systems, and I'll talk about what the differences were. So you broadly have a focal onset, or what was called a partial seizure earlier. Now it's a focal onset seizure. You then have generalized onset seizures, and then you have unknowns. We won't really talk about the unknowns because they're not really relevant to us. But focal onset now is either with intact awareness or impaired awareness. Earlier, this was called a partial seizure or a simple partial seizure if they were aware, and a complex partial seizure if they were unconscious or if they lost consciousness. This is now changed to focal onset with awareness or with impaired awareness. So small change, I think, good to know. So let's start with our focal onset seizures. How do we tell our focal onset seizures? I can't keep saying, I keep mispronouncing seizures. Oh, it's bad. How can we tell them apart from our good old friend, the generalized tonic-clonic seizure? So focal seizures may or may not have impaired awareness, as we just talked about, while GTCSs almost always have a loss of consciousness. Motor symptoms, if they do exist, are usually on one side, but this versus GTCS, where they usually are global. We also see a whole range of automatisms in focal seizures that aren't really seen in general tonic-clonic seizures. And these include things like lip smacking, excessive blinking, tapping, random movements. What an automatism basically is, it's a random movement that's uncontrolled and repetitive. And I'll talk about how that works. And I think a lot of things will be a big brain moment in a hot second. So stay with me. So as the name suggests, focal seizures have a focal origin. Why is this important? Well, firstly, it makes us wonder, is there something specific in a part of the brain that's causing seizures? And you'd start wondering that, especially if the person has had a few seizures or a few episodes. And it also guides the choice of anti-epileptic. So if you know that the person is predisposed to having focal seizures, your choice of anti-epileptic will be slightly different. We might go for something like carbamazepine as compared to sodium valproate, which is more so used for general tonic-clonic seizures. But we'll get to treatment in a bit. In our PSP fashion, where we try to understand and not memorize, we shall understand all of these manifestations, and that would make you seem really big brain and as if you know your stuff. So we have motor symptoms, sensory, we have the impaired awareness part of it, automatisms that I talked about, and two new terms, a Jacksonian march and Todd's paralysis. So here are the different parts of the brain, as you're aware, and we have different parts of the brain. We have different lobes: frontal, temporal, parietal, occipital, temporal, parietal. All of them are responsible for different things. So I've added this slide for reference, and Here you can see the different parts of the brain and how seizures usually affect them. But talking about motor symptoms, because a lot of these affect the temporoparietal lobes, which is where you have your primary motor cortex, you would imagine that a seizure or uncontrolled bursts of electric activity in that area would trigger motor movements, right? And because these are focal, they are usually unilateral, but they can trigger a chain reaction as well, where it starts off in one place, but then spreads everywhere else. And that is called a focal to a bilateral tonic-clonic seizure. Relatively straightforward. As you can imagine, this transformation from one type to the other can be very hard to differentiate from a generalized tonic-clonic seizure to begin with, but that is not something I want you to worry about at this point. As you can see, you have the motor cortex right here. So any bursts of electric activity affecting this part would cause motor symptoms. And here you have the homunculus model, as we talked about. So depending on which part of the brain is firing, you can have these motor symptoms in different parts. So if you have most of the lateral parts being affected, you might present with twitching of the face, lip movement, hand flinging, and if it's the medial part, you might present with shaking legs or random contractions or tonic-clonic movement at the legs. The very same thing goes for your sensory symptoms. Now you can have sensory symptoms that are auditory, visual, gustatory, spatial, and vestibular. So auditory, straightforward, you hear things. Visual, you see things. Gustatory, you taste things. Specifically ask for a metallic taste in their mouth. Spatial and vestibular are a bit different. Spatial symptoms seem like you are in a different place, kind of a thing. It's a poor knowledge and understanding of your immediate surroundings. Vestibular has mostly to do with balance, but those are relatively rarer compared to the rest. So let's talk about consciousness and automatisms. So we learn them, but I don't think we understand them really well. So let's go through them. So I just talked about how with focal seizures, you can either have focal seizures with impaired awareness or with intact awareness, right? Now, you ask yourself, well, Karan, if they're both focal and if they're both affecting a part, well, what determines whether you lose consciousness or you don't? Great question. Also important to note that when we talk about this loss of consciousness, it's not similar to the loss of consciousness we get with things like syncopal episodes. Instead of them just collapsing, it's more so they could have a blank stare, they could not be reacting, they seem awake, but they somehow are lost and unaware. A good question to always ask them is, do they remember what happened? And that is often a good indicator of whether their awareness was intact or it was impaired. The part that determines whether their awareness is impacted is a center in the temporal lobe called the mesial center. Now, you don't need to remember this, and it doesn't come up on exams, but it's really good in terms of understanding why these things happen and putting everything together in kind of a relatively structured format. So we have the mesial center, and if that is affected, you can end up with impaired awareness. Hope that makes sense so far. So your focal seizures affecting, obviously, any part of the brain. If it affects specifically the mesial center in the temporal lobe, you can lose your awareness, and that would lead to focal seizures with impaired awareness. Then we talked about these weird automatisms, these repetitive movements that the patient is not aware of, that stuff like lip smacking, blinking, putting their tongue out, hand flinging, and so on. So the way I like to think of them is, we already talked about focal seizures with impaired awareness starting in the temporal lobe. Why? Because this is where the mesial center is, right? And for this reason, a lot of these seizures are also called mesial seizures. Now, in addition to the uncontrolled electric activity affecting the mesial center, if it goes slightly ahead and affects the motor cortex, then you end up with an automatism. And that should make sense looking at this diagram, right? This is the temporal lobe here, right? And if you imagine, if you knock out someone's awareness and then chuck a burst of electric activity in this part specifically, because remember, temporal, not parietal, the mesial center is located temporally, you're going to end up with movements of the tongue, movements of the face, of blinking, of hand movements, way before you end up with toe movements or moving the leg or the lower body, right? Does this make sense? And it kind of makes sense because a lot of these smaller parts that are physically smaller occupy quite a large topographical space on the temporal lobe through the, as you can see through this homunculus module. So an automatism basically is a burst of electric activity in the motor cortex plus someone whose mesial center you hit, so they have impaired awareness. So now they're moving their tongue, they're moving their eyes, they're moving their lips, but they have impaired awareness because you've also hit out the mesial center, which conveniently enough is in the temporal lobe. At this point, I'm sure your brain is going boom and wow, that was so interesting. Was that interesting? I don't know. I really found that interesting, and I felt really smart for like a good 10 minutes after that. Alrighty. Moving on. As I mentioned before, you can have a burst of electric activity that starts in one place and goes to another, right? It doesn't mean that just because you started off in one place, it should end in one place. I talked about how you can have a focal seizure then converting into a bilateral tonic-clonic seizure. This is where I'd like to introduce the concept of a Jacksonian march. So going back to our previous example with the, let's say, with the homunculus man, let's say if you have a seizure that starts here and the person starts off with random movements of the face and the upper limb, twitching their neck and so forth, gradually this spreads, right, from lateral to superior. You're then going to have on the person's body movements that are first head, then neck, then their hands, then their shoulders, then their trunk, then their knee, and eventually their feet. So that's kind of going to be represented physically as a person flinging or moving parts of their body that's going to come in a wave or a march, and that's called a Jacksonian march. And as I said, you might start with some unilateral upper limb motor signs that then progress to lower limb. Again, big brain things. Next, we have something called Todd's paralysis. Again, named after some guy named Todd. I think, I'm not sure what he did. But basically what's happening here is kind of a short circuit, is how I like to think of it. You basically had bursts of electric activity that the brain is not used to, and now you've kind of tired all your neurons and they're going to be repolarizing for a while and not going to be firing at a same level. So you're going to have a period of reduced electric activity where even if you try, you're not going to be able to generate the same action potentials that you did earlier. A good parallel to that is if you've kind of done the equivalent of a 3-hour workout in about 90 seconds. And obviously that's going to be very draining, which is why people with seizures tend to be very tired for the rest of the day. And that's going to be also represented in your post-ictal phase. This behavior is very unlike my good gym buddy, Sneth. Shout out to you, Sneth, who does an absurd amount of Anki flashcards between sets and ends up spending roughly 3 hours at the gym every time we go. And here's this man, after a set of squats, going back to his Ankis. Love the man, but Sneth, please get off the Ankis. Thank you. And the Todd's paralysis basically means that you can't move your muscles. So it's kind of like a temporary paralysis of your muscles, but subsides over a few hours to days. Okay, moving on to our generalized tonic-clonic seizures. You can either have, as the name suggests, just a tonic-clonic seizure. You can have drop attacks and also absence seizures. The one I want to talk mostly about are going to be our generalized tonic-clonic seizures. These are going to be bursts of electric activity through the entire brain. Because of this, you're almost definitely going to knock out the mesial center. So you're going to have impaired awareness. And as the name suggests, it has a tonic phase, which means that the muscles contract, eyes rotate, tongue bite, loud moan, because your diaphragm also contracts. And this loud moan is commonly called an ictal cry. And this is when your whole body tenses up. Then you transition to a clonic phase where you get floppy, you typically fall, and then you have intermittent twitching of the muscles, which is what the shaking is. You then have the post-ictal phase, right, which is after you've kind of regained your consciousness, but it's very similar to what's seen in focal seizures, and is typical, and with post-ictal phases, you typically tend to be really tired, lethargic, can't really think straight. And again, this is going back to that principle where you fired a lot of neurons and your entire body just was twitching uncontrollably. So you're very tired and your muscles hurt and everything hurts. A post-ictal phase is a good way to distinguish epileptic seizures from other differentials, and we'll talk about those in a second. Absence seizures are also good to know. Most common in children. This is when your typical example would be a teacher notices that one of the kids in her class just kind of has a blank stare, looking out in the distance, doesn't respond. These usually last for a short burst of time, usually less than 10 seconds, and do not have any other manifestations, which is why they're called absence seizures. And they can happen very, very commonly, up to 100 times a day. And they're associated with amnesia, where the kids actually don't remember this happening. A common buzzword is that you have also this clinical situation, and on an EEG, you might notice a 3 Hz spike and an epileptiform discharge. Now, I do not know what an epileptiform discharge looks like, but I would really, really hope that you are not expected to either. Now, what else could look like the seizure? Now, this is really important when you have a patient come in where they tell you, doc, I've had a seizure, and you need to ask yourself, well, is this something else? Could this be a non-epileptic seizure? And what does a non-epileptic seizure mean? So a non-epileptic seizure means that they have had some shakes, they might have had kind of those contractions that look like a normal epileptic seizure, but it's a bit different because the cause might be psychogenic. So there might be a psychological cause behind it, right? And this is quite common in people with extensive psychiatric histories. It typically lasts for longer than 5 minutes, while epileptic seizures do not. If they do, then that would be called status epilepticus, which is a medical emergency. And they usually have their awareness being unaffected, so they can remember what has happened, and they don't have tongue bite, which is very typical of epileptic seizures. They could have had a panic attack, which again might present with palpitations, an overwhelming sense of anxiety, fear of dying, or a sense of impending doom. Syncope and presyncope, because they might lose consciousness, collapse, and they might even have a few jerking movements. But what's important is that they don't have a post-ictal phase with syncope and presyncope. A stroke and TIA as well, because they can have, again, impaired awareness with loss of muscle control. However, the consciousness is usually preserved, and your typical demographic for a stroke is going to be slightly different to that of an epileptic seizure. It is very rare to present with an epileptic seizure for the first time at the age of 72. You can have a migraine with aura, and this might be commonly confused with focal seizures, because focal seizures, as I suggested, may have a sensory component, so it's important to distinguish the two. And breath holding spells, quite common with babies, where they might, after crying for a long time, they might have a long expiratory phase and then hold their breath for a few seconds and have an apneic episode or breath holding spell. They can have a few minor twitches, but then they recover pretty quickly. So always ask what they were doing at the time and if they were crying, especially if they're a young child. Other things that are important is always ask if the if there was anyone around them who saw the event and can describe it, or if they have a recording or a video of the actual event. Some important things to consider. If you have a new onset seizure in an adult, always look for secondary causes like tumors, electrolyte disturbances, infections, and so on. Determining the exact type of seizure is important. So if you have someone you can take a collateral history from, please do. Alternatives include admissions for EEG and video telemetry. Presence of tongue bite is almost always indicative of an epileptic seizure. I mentioned the EEG. A seizure of more than 5 minutes is a medical emergency, and that would be called status epilepticus. And when you do treat patients in the short term, it's really, really important to educate them well on what epilepsy is or what seizure disorders are, things to avoid. So don't take long baths, don't lock the bathroom, don't swim or don't swim unattended, and what to do if you have another seizure, right? When to call the ambulance. Most patients with epilepsy might be given an epilepsy kit, and that might contain both medications if the seizure doesn't subside and other information on what to do. In terms of acute management in the community, you want to record the time of onset to know how long it's been going on for. You want to protect the head from any jerking movements, make sure it doesn't hit anything. Really, really important that you do not try and restrain these patients. You clean the surroundings of any danger, and you call the ambulance if the seizure doesn't subside in 5 minutes. In hospital, you'd pretty much do all of the same. If, again, it's more than 5 minutes, you'd call a medical emergency team or a med call. You give them diazepam or phenytoin as second line in the event of status epilepticus. Give them oxygen because they're not going to be breathing effectively, because one of the muscles affected is also going to be the diaphragm. And you monitor their vitals and EEG. An EEG might give us a good idea of what the seizure type actually is. In terms of chronic management, a partial seizure, as I mentioned earlier, we would give carbamazepine. In terms of this table, I think it's a good idea to memorize the names of certain anti-epileptics. It does come up on exams, so at least know what's first line for each type. Right? Partial seizures, carbamazepine. Everything else, sodium valproate. For GTCS, the second line is ethosuximide, while for absent seizures, it's carbamazepine. And here is, again, a flowchart taken from AMBOSS that talks about the general pathway on how to proceed when you have a patient presenting with a tonic-clonic seizure for the first time. And that's all we had for seizure disorders. Thank you all for coming or watching. If you have any questions, please feel free to get in touch. I hope that helped. And as always, please look after yourself and please look after your loved ones.